Okay, so you know that we said that bradycardia is never who you see first. We also said that bradycardia asymptomatic, where the patient doesn't even know it exists, is not a concern. But now what about the patient where, yeah, there is a concern and maybe we caused it and things are getting worse before they get better? This bradycardia is of concern. You know, if you looked at the last video, that I gave you a select all that apply with the causes of bradycardia. Now let's treat the bradycardia. So you know that the patient with the bradycardia, as ordered, would be several different things that maybe are thrown out to treat this patient. I have a trick where that's concerned. You know, sometimes tricks are good, sometimes too many tricks confuse you because you confuse the tricks. But that's why I don't give a lot of tricks. Some reviewers give a ton of tricks and mnemonics, and honestly that causes a lot of people to fail when they confuse all the tricks and the mnemonics. These tricks are solid evidence-based tricks that help the student. Trick number 1. If the patient is unstable and meds didn't work, then if the rate is fast, we cardiovert. That should make a lot of sense. So in the patient with really fast, crazy heart rates, if the meds don't work and we're unstable, then we cardiovert. It's that simple. If, on the other hand, the patient is unstable with a very, very slow heart rate, such as maybe heart block or bradycardia, and they're unstable and the meds did nothing, then we switch to transcutaneous pacing. So that's important. Cardioversion versus transcutaneous pacing. Transcutaneous pacing is for the slow, unstable, medications didn't work. Cardioversion is for the fast, crazy, weird, deadly patterns and the meds didn't work. Okay, so there's a nice distinction. So let's deal with the bradycardia that is just symptomatic. We don't like it. Your physician or your nurse practitioner is on board with let's treat this. And the treatment, of course, is atropine. Now you've got to know that title or that medication, because we use atropine for a lot of different things. But in this situation, we're using atropine to increase the apical. A for atropine, A for apical heart rate. And in this situation, this patient is unstable. They're definitely symptomatic. They're not getting better despite the fact that you didn't give any more metoprolol or you never gave that calcium channel blocker. They're not getting any better, and we don't have a good concrete reason for why this is even happening. And if we do, maybe it responds as well to the atropine. Now, I'm always going to give you the latest. Unfortunately, some of you go to nursing programs and they still teach old stuff. Like if your nursing program taught you MONA, that's sad, because MONA is no longer applicable for the MI patient. If you learned in school that 0.5 of atropine is what we use, that's outdated. In 2020, the American Heart Association updated their guidelines, and so the current dose of atropine is actually 1 milligram. The patient would need 1 milligram every 3 minutes, and this of course is in your crash card and different places you can find at work. But the point I'm making is this is one of those emergency crash cart medications, so it's always in a crash cart. You don't have to worry about that, but it is 1 milligram every 3 to 5 minutes for this patient's bradycardia. Let's say that did not work, and it's highly likely it may not work, although in my experience it works quite well. If it didn't work, then we have to consider as a team, right? Because sometimes we suggest it, sometimes the doctor suggests it. We have to consider transcutaneous pacing. And this is a very scary sounding type of procedure. But if you are at the workplace and you know that the patient is in a way is their situation is so concerning that maybe you called a rapid response, or what we call at my job, an AMED. If that's true, then you already have the equipment in the room to do transcutaneous pacing. It's called a Zoll, right? It may be a brand name, but it's called a Zoll. And on the Zoll, you have your analyze and all this stuff, and you have your pacing. If you go the opposite way, it's cardioversion, right? So this is transcutaneous pacing. Typically, in a patient whose bradycardia is going to last more than one episode, and this is something that we're concerned about long term, you already know the patient's going to be scheduled to get a pacemaker. And so pacemakers are going to usually kind of keep the patient stable long term. But for now, you got to get this unstable guy under control. So we do the transcutaneous pacing. So what did you learn? Right now, you should have under your grip all the causes of a bradycardia. We talked about electrolytes causing it. We talked about some endocrine disorders causing it. We talked about maybe this patient's healthy and they're athletic. We talked about some neuro issues. We talked about a lot. We may or may not have even mentioned frostbite, something simple. It's cold outside. Cold decreases the heart rate, heat increases the heart rate. So, you know, you're doing all this stuff. You're trying to analyze what's going on with your patient. But the most important first nursing action is to ask the patient, how do you feel? Do you feel any chest pain? Do you feel dizzy? Do you feel lightheaded at all? Did you maybe wake the patient up? So none of that applies. Make sure before we do anything, we've taken a set of vital signs. We've checked the SpO2 with the pulse ox. Just work it up, right? Work it up on your best way. And then, of course, when you page that provider, you've got all your information there in the page. You've got the room number, you've got the patient's last name, you've got the actual vital signs, you've got the concern with why you called, you've got all that handoff type of stuff in your page. That's important. Now, this concluded bradycardia. Next will be tachycardia. So it's the polar opposite. So get ready. Things may get a little juicy there. Okay.